My name is Stefan Stortecky. I'm Associate Professor at the University of Bern. I'm the Director of the Pulmonary Embolism Program at the Cardiovascular Center here in Bern, Switzerland. So we know that a substantial proportion of patients with acute pulmonary embolism, which is approximately 1/3, is considered to have at least one contraindication to thrombolytic agents. For example, a previous history of ischemic stroke or any other intracranial condition like neoplasms or metastasis. They may be considered an absolute contraindication for thrombolytic therapy. The same for recent surgery or trauma or any kind of hematological condition that may increase the risk of bleeding. And in case of acute pulmonary embolism, and if the treating physician or the pulmonary embolism response team determines that intervention is warranted or required, these patients are not ideal candidates for catheter-directed or systemic thrombolysis, and you need to have an alternative treatment solution for these high bleeding risk patients. So indeed, mechanical thrombectomy allows for thrombolytic-free interventional treatment, which is an option for patients with contraindication. However, outcomes in this specific patient group have not been described in prospective studies. So PEERLESS is a randomized controlled trial that compared interventional treatment with large bore mechanical thrombectomy versus catheter-directed thrombolysis for the treatment of intermediate risk pulmonary embolism. The study design also included a parallel registry for otherwise eligible patients who could not be randomized due to having an absolute contraindication to thrombolytic therapy. Patients enrolled into this non-randomized contraindication cohort, they underwent large bore mechanical thrombectomy with the FlowTriever system. We were able just to enroll 142 patients into this contraindication cohort, representing roughly 20% of all patients enrolled in the study. 60% of those patients were enrolled based on explicit absolute thrombolytic contraindications, such as recent intracranial or intraspinal surgery, recent serious head trauma, high-risk intracranial conditions, active bleeding or stroke history. And 40%, and this was interesting, they were enrolled based on investigator-determined absolute contraindications, such as another recent or scheduled surgical procedure, prior cancer diagnosis, or the suspicion of active cancer. Overall, as you may expect, those cohort patients, they had significant medical histories and more negative prognostic factors than randomized patients at baseline. 57% of those patients in the contraindication cohort, they had an elevated VTE bleed score, and 1/3 of patients had common relative contraindications, including recent surgery and anemia. And 1 in 4 cohort patients had other risk factors, including active cancer and renal dysfunction. We also found that cohort patients, they had a higher PASI, simplified PASI score, lower blood pressures at diagnosis, and a higher rate of NYHA class 3 or 4 when compared with randomized patients. So in the contraindication cohort, large bore mechanical thrombectomy was successfully performed with no in-hospital mortality or intracranial hemorrhage. One of the most interesting findings from this high bleeding risk cohort was the 7.0 major bleeding rate, which was, for context, is nearly identical with the 6.9% major bleeding rate that was observed among randomized study patients with low bleeding risk. The rate of device-related major bleeding was 4% in both the contraindication cohort and the randomized large bore mechanical thrombectomy arm. The rate of in-hospital clinical deterioration in the contraindication cohort was 3.5%, and none of the patients required escalation to bailout therapy. Consistent with the results from the randomized large bore mechanical thrombectomy arm, less than half of patients had post-procedural ICU admission. Longer hospital stays, more 30-day all-cause readmissions were, however, observed in the contraindication cohort, somehow reflecting the high rate of comorbid conditions in this patient population. Post-procedural improvements in pulmonary artery pressures, in vital signs, in right ventricular imaging assessments, and in clinical symptoms and related scores were numerically similar across the contraindication cohort and randomized large bore mechanical thrombectomy patients. All-cause mortality amounted to 3.9% during the first days, and there were no treatment-related deaths. So the results of this study substantiate the safety and the effectiveness of large bore mechanical thrombectomy for intermediate risk PE in comorbid patients with high risk of bleeding who are ineligible for treatment with catheter-directed thrombolysis. The similar major bleeding rates in this population suggests stable bleeding risk with large bore mechanical thrombectomy due to inherent treatment factors like the potential for procedural blood loss or exercise complication, rather than the bleeding risk driven by patient characteristics. This perfectly aligns with the thrombolytic-free device mechanisms of action, which relies on a syringe-based aspiration with the option for blood return. Additionally, results demonstrate similar device performance and early patient recovery can be achieved with the FlowTriever device in a population with significant comorbidities. So currently, the field is limited by the lack of randomized controlled trial evidence demonstrating benefit of interventional treatment over anticoagulation alone for intermediate risk pulmonary embolism patients. And we are very much looking forward to examine the outcomes between interventional strategies and the standard of care anticoagulation in ongoing trials, which is the PEERLESS 2 trial that evaluates the FlowTriever system versus anticoagulation, and also the HiPITO trial that investigates catheter-directed thrombolysis versus anticoagulation alone for the treatment of intermediate risk patients.